interventions. When you have you need a supported, in fact, earlier we even used ECMO as a support. Now, of course, 2.5 impella is in state of art and standard of care. Acute MI with shock or reversible heart failures like myocarditis, poisoning. So, Dr. Sanjay has mentioned the SCI or SCA classification. We actually mostly depend on the Intermax classification because that helps us for even LVADs and patients going for transplant and bridging, etc. So, in which the Intermax 4, 5, 6 are the milder grades of heart failure, which would correlate with milder grade 4 NYHA or 3 NYHA. And 1, 2, 3 are the severe grades. So, for example, 2 are patients who are sliding faster on inotropes going into cardiogenic shock, and 1 is, of course, Intermax 1 is patient also near cardiac arrest, becoming more sicker. So one of the earlier trials I'd just like to mention just for perspective is a shock trial. So it was about 20 years back, and that time acute MI was the first trial to actually highlight the problems in cardiogenic shock. So in which there are two types, they divided patients into two categories. One which had just emergency initial medical stabilization with the thrombolysis or an IABP, etc. And maybe delayed revascularization. Another category was emergency revascularization. So that time, this emergency PCA was not the state of art. But in this patients, one category of patients, they tried IABP and PTCA, emergency, or some cases even CABG. And then, but they found that even when the plasty is successful, still the mortality rate or survival is about still high, about 40%. So that is one of the problems which we have been facing for the last so many years, in which acute MI mortality remains the same. So traditional solutions for cardiogenic shock would be inotrope, dopamine, adrenaline, IABP, correct acidosis, do diuretics if a patient is congested. So one of the first mechanical circulatory device was IABP, just to reiterate, and that actually was one which is simple to use, and it has been found useful as the first line of therapy for advanced LVA for heart failure or cardiogenic shock, especially in acute MI cases, we used to use a lot. We are also using as a bridge to transplant in patients who are advanced heart failure. But this therapy, although initially there were some small trials showing that IABP is useful as adjunct to thrombolysis or PTCA in cardiogenic shock. But of late, there seems to be a lot of data coming that it really doesn't benefit, like this IABP shock 2 trial, which really didn't show, in the RCT pattern, it didn't show any advantage or survival advantage of IABP over control. So overall, our mortality with acute MI, especially acute MI cardiogenic shock, remains the same in spite of using all the varieties of MCS for the last 10 to 15 years. This was prior to the Impella or ECMO coming into vogue. So we have two types of ECMO basically programs when you see practically as far as India is concerned. So one is acute stabilization when you want a decision or when you want a support in a cath lab situation, or you have integrated program as a bridge to heart transplant or bridge to recovery or bridge to LVAD. So what exactly is ECMO? What are the actual catheters we use? So basically we have arterial cannula, which is now easily available by Medtronic. Medtronic introduces percutaneous cannula available in India from around 2013. And basically, the arterial side, we use 21 to 23 French. Venous side, arterial was 18 to 21 French. Venous side was 21 to 23 French. And we use a distal perfusion to basically as a protect the limb from limb ischemia, the distal part of the limb. So if you compare the sizes, for example, IABP 7 to 9 French, ECMO is higher grade. The arterial will be 18 to 21, venous would even go up to 23. Tandem heart is 21, Impella 2.5 now is 13 French. Impella 5, which we have used for the bridge to transplant, is higher, 22 French. So these are the comparative sizes. And there are, of course, flow, of course, what we need, what we get from ECMO would be higher than what we get from other devices. So the sheath sizes of different devices, this is because it actually this would pose a risk to the artery. So ECMO, venous 21, 23. The other device which are used here in some cases is a device called Pulsecat, which is again 23 French sheath. Impella 2.5 CP, as I mentioned here, 13, 14, 23. A tandem heart arterial would be 12 to 14, venous is 23. Protect duo and all are used on the right side, which larger cannulas 26, 29, impella RP is 23. Still, we are not used in India. So the flows we get and hemolysis, IABP around 1.5 liters, almost no hemolysis. Pulsecat is one which is around 2 liters, mild hemolysis. Impella 2.5, we surely get hemolysis if used for longer duration. Impella 5 has mild hemolysis, but again, longer usage has. ECMO gives 4.5 to even 5.56 liters, and hemolysis is significant if used after especially long duration after a week. Surgical Centrimag pump is one of the least hemolysis, even with higher flows. So Centrimag can be used as an ECMO pump. So in that case, we find the hemolysis is less. So in our experience in the last 5 years in Dr. Bala's KRB's unit, we have used around 62 cases of VA ECMO for cardiogenic shock. Majority are for acute decompensated heart failure. Patients waiting for heart transplant, patient waiting for LVAD. You are in the peri-MI, post-MI situation or pre-PTCA, post-PTCA patient going with cardiogenic shock. You are ARDS patients. And of course, 25 and for as a bridge to heart transplant or LVAD. The experience, of course, we have also with other devices apart from this IABP, axillary IABP, Pulsecat, and Impella. We have used a few cases of 5 Impella, 3, 4 cases. So one of the first protocols which came out was from Pittsburgh for VA ECMO in cardiogenic shock, in which they just mentioned about the exclusions which are important and how long you can wait when the CPR is there and how fast you can start on ECMO if there is no return of central circulation or brain circulation. So the contraindications what came out of this protocols were that age is more than 75, 65 to 70 and patient not awake, less than 60 and more than 20 minutes of witness CPR or with focal neuroscience. There is end stage cirrhosis. There is significant AR, especially more than trivial. Other exclusions, sepsis, severe peripheral vascular disease, not a candidate for bridge to recovery due to various diseases, previous strokes, etc. Our observation on ECMO, what we find from our cases are that cardiac output significantly improves, pH improves. After that, like the average would 7 to 7.37. Wet pressure significantly comes down, lactate improves. Urine output surely improves most of the cases. This is one important thing that the cost. So, for example, if you use tandem heart, even we had done as a specific hospital to direct component hospital import around 25. Impella device is anywhere 28 to 24 lakhs INR. But a Mackay Rotaflow ECMO pump with a quadrox oxygenator still is around 8 lakhs. This is apart from the ICU charges, per day ICU charges. It's only for the device. So this is one of the old model ECMO which are used in Fortis Malar 2010. It is actually a biomedicus pump from Medtronic and an older model oxygenator. These were cases which you used first as in patients with MI or cath lab crash. And many of them didn't recover with severe bleeding and hemolysis. The later models which are available now, of course, as you know, this is arterial cannula. This is a distal ATF used for distal protection of the artery and a venous cannula. And then we actually started having this Rotaflow Mackay and now the CardioHelp Mackay pumps. Or Centrimag also we are used as a pump. And the Quadrox as a standard oxygenator. The Quadrox oxygenator of ECMO is one thing which causes least thrombocytopenia and we have a lot of faith on it. And we have even used it up to about 4 to 5 weeks even. The Quadrox, single one, without change. Cannulation, arterial cannulation, basically we want a fairly good flow, 3.5 to 4 arterial, standard would be 20, 22 French, and venous around 24, 23, 24 French. All are available in percutaneous cannulation kind of, the device is available and easy to deploy, as Dr. Sanjog said. Now about a bit of physiology of VA ECMO. As you know, it's a non-physiological retrograde path. So surely some cases you get what he has mentioned as north-south syndrome. So the upper part of the body might get a less of oxygenation. It reduces the LV preload. It also reduces the right atrial pressure. That is very important. So if somebody has a RV failure and high RA pressure, it is the one which reduces because it actually unloads the right side. But left ventricular end diastolic pressure might persistently be high. There might be high pulmonary congestion. Because of gas exchange and membrane oxygenator, you get fairly good oxygenation. But limb ischemia could be a problem. And sometimes you may get LV stasis like this with thrombus in the left ventricle. So what are the hemodynamic benefits of VA ECMO? Reduce RA pressure, so it could be renal protective, improves cardiac output, reduces acidosis, arterial oxygen is improved. But LV preload, although it reduces theoretically myocardial oxygen demand, still a problem of high persistent LVDP is there. So there might be need to unload the left ventricle. So the problems in VA ECMO usage are immediate high afterload. Sometimes when you just insert afterload, it's very high, flows are less. But you correct the afterload using some minor drugs, milrinone, NTG might be needed. The flow improves. Reduce oxygen from upper body, limb ischemia, persistent pulmonary congestion. Thrombocytopenia, hemolysis is a problem of basically the oxygenator. And with Cordrox, these problems are minimized as much as possible. Pump thrombus, air embolism, these are some of the other issues which especially the pump operators, people who operate the perfusionists have to take care of. What are the solutions? As I mentioned, for high afterload of pharmacological measures, milrinone, NTG, upstairs, downstairs syndrome, that is Nostos syndrome, we correct the ventilator setting, we reposition the cannula. High LVDP, IABP is one simple solution. It has worked sometime. As Dr. Sanjog has said, Impella is one thing which now has been found to be useful in reducing the high LVDP. LV apical vent, we have used sometimes when patient cannot afford an Impella. The problem here is affordability of Impella, which is 20-25 lakhs. ACT has to be maintained with heparin to avoid clots, Cordrox oxygenator, meticulous care for air embolism. And again, these are various strategies for venting. There are some centers which are even using atrial septostomy. Other centers are used like reducing pump flow to reduce the LV afterload, etc. Inotrope sometimes, just play around with the inotrope. These are various things people are used in the absence of an Impella. We cannot afford an Impella. So what are the studies which are data which I just chosen a few because one data came out from the ELSO study to 2017 SIO journal. It has mentioned about 56% survival with ACLS immediate and survival to discharge around 40-41% in cardiac cases. So the ELSO registry also mentioned 41-42% survival to discharge, 56% immediate survival, but the survival was higher for myocarditis, possibly because of more in recovery, myocardial natural recovery, and 37% for congenital heart disease cases, that is less for CHD cases. Of course, the earlier trial from Taiwan surprisingly showed that ECMO-assisted primary percutaneous PCI has a much significantly about two times higher overall survival compared to not using an ECMO. This is basically from Taiwan where they use a lot of ECMO. O'Neill from Journal of Internal Medicine in 2016, he had done a meta-analysis in which again he showed that ECLS is significantly better than IABP overall, but there no significant improvement of benefit could be shown when compared to an Impella with ECLS. But as Dr. Sanjog said, a few trials which has come out now probably shows a better outcome with Impella in acute cardiogenic shock. So these are other studies from Jack. Again, shows a slight benefit of ECLS over not using ACLS in acute MI. So what are the reasons for high mortality in spite of using an ECMO or on an ECMO? One is, of course, the LV function doesn't recover even after PCI. Myocardial stunning could be a factor, which of course. Other thing is LV aneurysm or patient developing acute MR, VSD, etc. High LVDP, persistent with high LA pressures, unvented heart. Multi-organ failure is a significant problem. Kidney problem, liver dysfunction, kidney dysfunction, sepsis. These are practical real-life problems in the ICU. Bleeding is a big issue in many cases with hematological problems, including hemolysis, which can otherwise reduce the survival overall, especially when you use for longer duration, because we tend to use it more in weeks rather than hours, especially in other cath lab-based ECMO. Sometimes are used for short duration. We actually have to use it for longer duration, 1 or 2 weeks, and then there's a bridge to transplant or LVAD. So thank you for the patient hearing, and we open up.